صباح الخير وأهلا وسهلا بكم جميعا في الأردن. Good morning everyone. I am pleased to welcome you to the 4th annual PCI MENA. I would like to thank my colleagues for all their hard work. And I would also like to thank all the guests for attending this conference. It brings me the great pleasure and honor to be here with you. As you may know, this year's conference will be held over 2 days. On the first day, we'll be discussing different topics regarding left main, imaging, calcified lesions, congenital heart disease, and vascular issues. On the second day, we'll focus on structural heart disease and complication sessions. And I know everyone likes these sessions, and I hope you find these sessions and cases interesting. I would like to welcome Dr. Yousef Goussous, the President of Jordan Cardiac Society, to share his wisdom with us all. As you know, Dr. Yousef Goussous, founding father of interventional cardiology in Jordan. The stage is all yours, Dr. Yousef.
الحضور الكريم، طاب صباحكم وطبتم صباحا وأهلا وسهلا في عمان الأردن. أهلا وسهلا. أسلم عليكم وأحييكم في هذا المؤتمر الرابع، مؤتمر القلب التداخلي للشرق الأوسط وشمال أفريقيا. الحضور الكريم، أتمنى لكم مؤتمرا متميزا، وأشكر القائمين على هذا المؤتمر بداية الدكتور محمود واللجنة المنظمة للخروج بهذا المؤتمر المتميز. وأعتقد أنه خلال اليومين، اليوم وغدا، سنستفيد كثيرا. وحيي الأهل والزملاء من الدول العربية الشقيقة، من فلسطين أولا لأنه لها وضع خاص، والمملكة العربية السعودية والعراق وكل أهلنا من جميع الدول العربية. أنا الحقيقة اسمحوا لي المرة هذه بدي أحيد عن النظام التقليدي. حضرت إنه مؤتمر وألقي كلمة، بدي المرة هذه مثل ما بيقولوا to deviate وأحكي لكم قصة قريتها في New England Journal of Medicine. very interesting story. اسمها ايزنهاور $1 بليون هارت اتاك. كيف عولج رئيس الجمهورية الأمريكية قبل أكثر من 60 عاما، وكيف أنتم تعالجون القلب الآن بإنجاز والتقدم اللي حصل. فهذه منشورة في نيو إنجلاند 22 سبتمبر 2005. 50 years ago this week، طبعا 2005، Saturday 24th 1955, President Eisenhower was playing golf at the Cherry Hills Country Club outside Denver. On this 9th hole, he started to complain about an upset stomach. He suspected that was an indigestion since he had eaten a hamburger with slices of Bermuda. يعني همبرجر من هذيك الايامات كان موجود ما شاء الله يعني شنع فينا الهمبرجر فاعتقد انه اكل همبرجر وشويه stomach upset. Nonetheless, he decided to call it a day, ينهي يومه, and he resumed home shortly. And after midnight, he woke up with severe chest pain. He asked his wife, Mammy, for milk of magnesia. يعني مشان الستومك حموضة والبرجر والسلافة. But she was concerned enough to call his personal physician, Dr. Howard Sidney, who arrived at the president's bedside at 2 a.m. وصل. According to his diary, Cinder gave Eisenhower amyl nitrate sneezing, amyl nitrate sniff, and morphine and pavavrin. أعطاه pavavrin ومورفين. According to his diary, قلت لك he injected him, the president fell into a deep sleep, not to awake until 11 a.m. اللي هو كان يوم Sunday. His chest pain persisted. However, and an electrocardiograph was brought, جابوا له جهاز من المستشفى العسكري. أمريكا البريزيدنت راح جابوا له جهاز من المستشفى العسكري مشان يعملوا له تخطيط. Brought from the army hospital. It recorded an anterolateral myocardial infarction. كويس كان يعرف يقروه هذيك الأيامات. And the president was hospitalized. More than 24 hours had elapsed since the onset of his first symptom of myocardial ischemia. Since only army doctors were involved, Vice President Richard Nixon Maghero, who became the president, thought it was advisable to call a civilian heart specialist. وبعدين جابوا Dudley Hart من Mass General Boston. Dudley Hart يقولوا عليه father of cardiology in the United States. جابوه في طيارة خاصة, one of the Americans' former cardiologists, who arrived at Denver by a military aircraft on Sunday morning. During the physical examination, he noted a pulse rate of 90 per minute, blood pressure of 115/65, auscultation, the heart revealed a friction rub. Serial electrocardiograms showed ventricular and supraventricular ectopic beats. The president, convalescing under oxygen tent, was given intravenous heparin. News of Eisenhower's myocardial infarction had a strong effect on the country, most immediately on the final market. On Monday, September 26, Wall Street panicked and shares went down to a tailspin. By the end of the day, the Dow Jones had dropped 6%, a paper loss of 14 billion. لما سمعوا عن هارت اتاك تبع ايزنهاور اكثر من قتل كندي ولما شاتوا شو اسمه البريزيدنت كندي ورونالد ريغان when he was shot. In response to such panic, reassuring statements came from the White House, but also some of the nation's leading cardiologist. فبتم يهدوا الناس قالوا لهم في كثير سنتس صابهم هارت اتاك وهم اوكي، منهم ليندون جونسون بالمناسبة اللي صار بريزيدنت بعد لما قتلوا كينيدي. On September 27, White House said in a press conference, I am returning to Boston, had a Dudley heart, as the president's condition is satisfactory and partially because he had such excellent attention medically and otherwise. White House attempted to dispel concern that the Gulf كانوا إنه الجولف اللي جاب أجله واللي هو اللي سبب له heart attack. On October 30, White discussed the event at the meeting. صارت الميتينج of the American Heart Association. فشو في نيو أورلينز. فقال لهم إنه شو السبب heart attack عم بيسبب شو risk factors at that time. Male, sex, age, active, ambitious personality, and heredity. Among the environmental contributors, he mentions stress and strain, diet and exercise. Factors that attributed to his attack. Eisenhower had started smoking when he was a cadet لما كان مرشح للجيش at West Point and was up to 4 packs a day كان يدخن. By the age of 59 years, where his doctor advised him to stop smoking, وقف. With regard to his cardiovascular system, Eisenhower's short-term recovery was uneventful. Just 5 months later, after his infarct on February 17, he played the first round of golf at the Glen Army Country in Georgia. Like many patients who had a cardiac event, he endured كان حالته بالويل مش كثير قوية. In June 1956, he had a small bowel obstruction, كان عنده Crohn's, and iliotransverse colostomy was performed. عجبكم بعد سنة أو أقل. Eisenhower was somewhat reluctant to trust the assurances. إجا انتخبوه مرة ثانية. نقاش طويل بتحمل ما بتحمل، دخل مرة ثانية ولاند سلايد جاب بال 56. On November 25, 1957, بعد ما انتخبوه بشهرين, the president suddenly noticed that he could not complete his sentences while speaking to his secretary. Occlusion of the left middle cerebral artery was diagnosed. أموره هذا هو president next term. كيف؟ بدي أختصر. In January 1961, in October 1965, he had the other serious myocardial infarction that ended in public affairs. From his first infarction in 1955 until his death in 1969, Eisenhower had at least 7 myocardial infarctions and 14 cardiac arrests. It was customary prolonged bed rest. المهم استفاد من الاي سي يو والدي سي فبريليتر اللي اخترعها برنارد لون. فالمهم he died in 1968 from a heart attack. وبس أنا حبيت أسولف السلافة هذه وأقول لكم كيف أي مواطن عربي الآن بهالوجوه الفرحة الممتازة أمامي اللي بخش على برايمري بي سي اي وثاني يوم وثالث يوم بروح. أنا لحقت وأنا في مصر وبعد 6 أسابيع مسكرين عليه، لا تعطس، لا تنام، لا تقوم، لا تقرأ جرايد، يصيبه constipation، ولا عندنا أي شيء نعطيه. فهمت علي كيف؟ حاطينه 40 ربعا زي المتخلف هسه تقعد 40 يوم ضارب. فشوف التقدم، الله يعطيكم العافية. بتمنى لكم مؤتمر ناجح بوجودكم انتم، وإن شاء الله بنشوفكم بخير، والمؤتمرات تتكرر نشوف هالوجوه الفرحة. الله يعطيكم العافية، وشكرا على إعطائي هذا الفترة. شكرا.
شكرا دكتور يوسف. احنا معنا وقت 15 minutes. انا I think خلينا نبدأ بالسيشن رقم 1. الأسماء موجودة. دكتور أيمن، دكتور عدنان، تفضلوا. دكتور إياس، دكتور سامر، والباشا دكتور يوسف. دكتور وائل، نحن سعداء دكتور وائل بوجودك اليوم معنا. دكتور وائل رئيس جمعية القلب التداخلية السعودية، أهلا وسهلا فيك. احنا رح نبلش مع هسا دكتورة مرفت أول. بتعرف دكتورة مرفت؟ لا احنا لخبطنا يا باشا. هاي لا قدم انت. دكتور ميرفت MCS كل MCS ميكانيكال كارتك سبورت.
يسعدني أن نفتتح هذا المؤتمر بكي نوت لكتشر من أستاذة معروفة الحقيقة ومبدعة من مملكتنا العربية السعودية، الدكتورة ميرفت. بدون ما أكمل أكثر، معروفة الدكتورة ميرفت الأسناج. أهلا فيك دكتورة ميرفت. تحكي عن ميكانيكال سبورت في الانترفنشنال كارديولوجي في هاي ريسك PCI. دكتورة ميرفت أهلا وسهلا ومرحبا. تفضلي. تفضل.
Assalamu alaikum jami'an, and thank you for the invitation. And it's wonderful to be here again. It's wonderful to be here again representing both the Saudi Arabian Cardiac Interventional Society and the American Society of Cardiovascular Angiography and Interventions. I was tasked today to discuss mechanical circulatory support for high-risk PCI. What I want to do very quickly is really go over the myth that we do too many PCIs and we use too much mechanical circulatory support. And then I want to go over really quickly ischemia per se, chronic coronary syndrome, and then, of course, show you a few cases. So how many of you use mechanical support in high-risk PCI, not shock? If I can just have a hand raise. How many of you actually use mechanical support? And how many of you have an actual policy on using mechanical support? Like, what are the indications or a point system or something in your centers? Are we okay proceeding from here? I think you captured what I was saying so far, right? We don't need to restart. Yeah. So we're starting with now the evidence for mechanical support in the setting of not shock, but high-risk PCI. The first is obviously intra-aortic balloon pump. The evidence comes from the British Cardiac Interventional Society's trial that really looked at in-hospital major adverse cardiovascular events, that is death, MI, and stroke, and revascularization. There was no difference in those who had elective intra-aortic balloon pump as opposed to those who didn't have any upfront planning to use intra-aortic balloon pump. The only difference is you do see a higher procedural complication rate down here that was statistically significant in those who had unplanned use or no prior planning of using intra-aortic balloon pump. But what I do want you to look at here is this next slide. The NNT is 25 at 5 years, but interestingly, what you do see is that all-cause death, when they followed up these patients out to 5 years, was actually higher in those who did not have planned intra-aortic balloon pump implantation or use during the procedure. Why is that? We don't know. What we do know is that both groups had the same amount of revascularization during the procedure. So what did change? Was it more aggressive medical therapy? Was it the balloon pump itself offloading or what have you? We don't really know, and I don't think at this point we can. Nevertheless, it warrants pause. Next, looking at mechanical circulatory support devices in stable patients. This came from the Cath PCI registry in the United States. Granted, it was 10 years, and so some of our practice changed during the course of the 10 years, 2009 to 2018, but it was over 2 million patients. And again, what's important here is to note that the total amount of patients that ended up getting mechanical support was only 6,000. That is 0.3% of the patients entered in the database. So there isn't overuse of PCI and elective use of mechanical support. What did they find? They divided them into two groups, those who got intra-aortic balloon pump versus other mechanical support. That means things that are bigger, like Impella and ECMO and so on. There was higher major adverse cardiovascular events with the balloon pump only group, but they had less complications. So just to kind of put it in graphic form, what we do know is up until a certain point, like around 2005, 2010 area, we see a steep incline in an uptake in the use of mechanical support, ECMO, Impella, but we do see a flattening or stagnation, plateauing of the use of intra-aortic balloon pump. What did that translate into? Well, it translated into higher deaths, cardiogenic shock, heart failures with the balloon pump compared with other mechanical support. Nevertheless, naturally, intra-aortic balloon pump, you're talking about an 8 French sheath, compared with the other ones, had less complications, including stroke, peripheral vascular complications, and so on. What was the commonest indication for using mechanical support in elective PCI? Really unprotected left main. And then you can see the others, 3-vessel disease and so on. Which brings us to the more recent data that we have. So looking at the PROTECT series. So I would be remiss not mentioning the PROTECT series when we're talking about mechanical support. So the early ones, you know, the Europella, US Pella, PROTECT 1 and 2, these were more like feasibility trials to kind of show you whether it's safe or not. Then we move on to PROTECT 3 and then what comes after PROTECT 4 and so on. But I want to start with the Restore EF that was published in JSky very recently in 2022. They looked at using mechanical support, namely Impella, in patients between 2019 and 2021. So this is a very contemporary cohort, recent practice. About 70 years age was the mean, about a quarter were women, and they looked at 90-day outcomes in these patients, looking at symptoms and quality of life, but they also looked at EF and survival. What you do see very clearly, if you look at the gray, this is New York Heart Association, where they had class 4. There was a significant reduction, and it went down to about 1%. You look at the angina class, again, when you look at the gray, 44 and 28%, that is class 3 and 4. After the PCI, it came down to almost 2%. So there was significant improvement in symptomatology and quality of life. Although we don't do PCI to improve EF, the Restore EF trial did, in fact, note that there was an improvement of the median EF from 35% to 45%. What that means, I don't really know. What's more important is that it translates into clinical outcomes of better survival. The PROTECT 2 trial, what it did look at was, again, high-risk PCI in patients with low EF, less than 35% with 3-vessel disease, or less than 30% EF with left main disease. But what you do see here that's very interesting, and effectively it showed no difference. So there was no benefit in using mechanical circulatory support, i.e. Impella, in these patients. But what you do see here, and it is important to look at it, that when they did the analysis by intention to treat, In the first 30 days, there was no difference, but after 30 days, the gap started to widen, and by 90 days, you do see a difference in major adverse events. But when they analyzed them per protocol, meaning they looked at those who actually got the assigned therapy, they looked at those who actually got the Impella versus those who did not, it starts much sooner that you see the divergence of the graphs with a favorable benefit to those who had Impella compared with balloon pump. So the major adverse events was much lower. Again, something to pause and think of. However, the totality of the total conclusion or the final conclusion from that is that at 90 days there was a trend, however, no significant improvement. Which takes us to PROTECT 3. PROTECT 3 looked at the PROTECT 2 group and tried to match them, getting patients again with very similar outcomes, with very similar parameters, and they excluded STEMI and shock patients. These tended to be older, they had more women enrolled, higher comorbidities, meaning stroke and renal dysfunction. And again, what you do see, the PROTECT 2-like compared with PROTECT 2, sorry, I'm jumping here, you do see that actually MIs, repeat revascularization, hypotension during the procedure, bleeding, etc., was much less in the PROTECT 3 compared with PROTECT 2. Are we getting better? Are we selecting our patients better? Are we getting better with PCIs and access? That's probably a contributor. And finally, this is the PROTECT 4 that is still enrolling. They're looking at Impella versus no mechanical support or balloon pump, which is now considered here. Again, they're looking here at, they're also including recent STEMI and non-STEMI, so it's not purely chronic coronary syndrome patients, and they're going to look at the usual events. These are the inclusion criteria, so they're actually looking at complex PCI, including left main, CTOs, vein grafts, and so on, which were previously excluded. So this is Impella. We finished the balloon pump, Impella, and now I'm very quickly moving to the last big gun, which is ECMO. Unfortunately, we don't have really big series or evidence for ECMO. The data usually is single center like this one, where they actually look at the patients, look at them, they're actually younger, 60s, majority are men. Not many have high comorbidities, but effectively these investigators saw that in their particular center it is reasonable to consider ECMO for high-risk PCI. I'm not sure it's generalizable, and I'm not sure that a small series, 14 patients only, is enough for us to now make statements and generalizations. And that's why when you look at the guidelines, so when you look at the American guidelines and the European guidelines, أخذوها من الآخر. They did not comment on the use of mechanical support in high-risk PCI outside the setting of shock. The Americans, what they chose to do is be a little ambiguous. It's level 2B, level of evidence is B. Now remember, this was discontinued after the PROTECT trial was discontinued effectively, and then remains not a strong recommendation to use support. This is the patient that I showed you. We ended up doing a 2-stent strategy, but what do you notice here? There's no mechanical support. So we were still able to do it because overall the patient's hemodynamics, LV-EDP, and so on were still reasonable, and it was safe to do it. And we were able to do IVUS as well for these patients, evaluate the left main and the LAD, looking at the bifurcation segment where that was the left main on top, and you can see the bifurcation in the middle screen, the middle over here. So this is the bifurcation with the circumflex, and in the bottom is the LAD bifurcation with the diagonal branch, and again you see widely patent. As opposed to this patient that I'm going to close off with. This is a patient who comes in with what you do see here, an inferior ST elevation MI, but you also see ST elevations in AVR. You know this patient is going to have something going on in the left main. So this was the POCUS, the point-of-care ultrasound that was done when the patient first came. Not terrible, but actually the EDP was extremely high and the patient's lactate was also high, but not shocked. So this is the RCA, and then we open the RCA, disappointing, very small vessel with diffuse distal disease. But then this is what the left system looks like. Since this was not shock patient, we opted to, not in the same setting, but during the same admission, to consider doing complete revascularization. Naturally, we had to do Impella for this patient. Naturally, the surgeons don't want somebody who had multiple risk factors, but also poor targets, diffuse disease everywhere. And so what you do see over here is distal disease in the LAD, where their touchdown for the surgeons is going to be, and then 2 bifurcations, really, the LAD diagonal and LAD circumflex. Again, intravascular ultrasound effectively shows you calcium that is just short of 180 degrees along the course of the left main and the LAD itself. Very quickly, we ended up doing spot stenting in the LAD with pre-dilatation and post-dilatation and not giving him a tube, and then directing our attention back to the two bifurcations that we had. So this is working backwards, forwards. We did the LAD diagonal and then moved back to work on the LAD, the left main and the circumflex. This is using eleocranial to just position our stent in the ostium. And then recrossing into the circ and doing a repot and a kissing inflation, and it was a very sharp angle over here that deterred us from using a second stent. And these were the final results. You do see the LAD and left main. You see well expanded and opposed stents, no edge dissections in either of them. But important to see over here that we chose in the LAD, it was a 90-degree angle, so tap was reasonable, two-stent strategy. In the left main, we opted for a provisional strategy simply because we didn't want to be left with a tube going to nowhere. All you have really in the circumflex is a tube over here with no obtuse marginal branches and very diffuse distal disease. So we really weren't sure about adding a second stent and adding risk of late lumen loss and in-stent restenosis subsequently was going to be of benefit. Interestingly, we did bring this patient back for evaluation for possible AICD after 30 days, and I'm not sure why this isn't playing, but the EF had a remarkable improvement. The echo is not actually playing, I'm sorry. But I think my last message to you is that we have to be selective. We shouldn't be, it comes at a cost, financial cost, but it also comes at a price to the patient in terms of risk, the use of mechanical support. So you have to use judgment on who are the patients who are going to benefit more from use of mechanical support. So thank you.
Dr. Iyad Azzam, with his talk about what does aggressive medical therapy truly mean. Dr. Azzam, he's Associated Interventional Fellowship Program Director, Medical Director of Complex and High-Risk PCI and Chronic Total Occlusion, Medical College of Wisconsin.
Good morning, esteemed colleagues and distinguished guests. It's with great pleasure to be presenting this case, and I would like to start with thanking the organizing committee and especially Dr. Mahmoud Izraiq for this kind invitation. And I'm especially delighted to be in my hometown of Amman. I'm Iyad Azzam, the program director, the medical director of CHIP and CTO program, and the associate interventional fellowship director at the Medical College of Wisconsin and Frederick Hospital in Milwaukee, Wisconsin, in the United States. So I'll be presenting this case. What does aggressive medical therapy truly mean? And I look forward to the stimulating exchange of thoughts and exchange of ideas. This is a 77-year-old female with non-STEMI, hypotension, shortness of breath, and chest pain. EKG on presentation. Yeah, EKG on presentation is as shown. She was found to have ischemic cardiomyopathy and with the EF of 43%, multivessel coronary artery disease, and moderate aortic valve stenosis. Her past medical history is significant for PE, DVT, breast cancer. She has left leg cellulitis, right above the knee amputation, diabetes, and her BMI is more than 32. Her medical therapy was optimized, as mentioned there. Her diagnostic angiogram shows left main artery disease, LAD, and circumflex. They are calcified. These are two other projections, and a non-selective shot of the right coronary artery is as shown. Her STS score showed mortality of 3%. So this case was presented to our weekly high-risk case conference at the medical college. The cardiac surgeons did not agree to proceed with CABG. Neither the patient did agree. She was referred to, the recommendation was to refer her to CHIP and CTO clinic, but the primary non-invasive cardiologist decided to postpone this appointment and wanted to see her at his office in 2 months. He also referred her to another cardiac surgeon at another big institution in Milwaukee. The recommendation was just the same. Then she saw another non-invasive cardiologist who told her the same message. PCI does not work, and PCI has no survival benefit. She continued to have daily chest pains despite all the anti-ischemic and anti-heart failure medications. She continued to take sublingual nitroglycerin, and then her primary care physician decided to send her to my CHIP CTO clinic, where we had an appointment and discussed the pros and cons of high-risk PCI, to which she and her family agreed. As was mentioned in one of the previous presentations, mechanical support is important. We do not have any validated scoring system. So I adopted or worked on one of the probably the algorithms you had seen before from the University of Washington. I modified it and came up with this algorithm or risk calculator for mechanical support. Basically, if you elect to do right heart cath, if cardiac index is less than 2.2, this gets that patient 1 point. EDP more than 17, 1 point. Presentation, EF less than 36 gets 1 point. EF less than 26, 2 points, and so on. Syntax score more than 22 gets 1 point. But syntax score is only for the vessels you'll be treating during that procedure. So we proceeded with high-risk intervention. Impella CP was placed using the single axis technique. We introduced a 7 French 45 centimeter destination sheath, then engaged the left main artery using a 7 French EBU 3.5 guiding catheter. The circumflex is totally occluded now with TIMI 0 antegrade flow. So we protected the left main by advancing a Sheehan blue wire down the LAD. Then we tried to intervene on the circumflex artery using multiple wires and different techniques. We used Fielder XTA, Pilot 200, Gaia Third Next, Fielder XT, and Gladius Mongo. They were supported with multiple microcatheters, but nothing was successful. So moving away from this failure mode, we shifted to a parallel wiring technique, and we're able to find the true lumen by keeping one of the wires in the subintimal space, and we're able to advance this wire down the circumflex. We confirmed being in the true lumen by performing a tip injection. Then we exchanged the wire out for rotafloppy wire and pulled the LAD wire out. We performed rotational atherectomy using a 1.5 millimeter burr of the left main and the circumflex artery. Multiple passes were performed so that especially the proximal to mid circumflex was very hard to penetrate. We prepared the distal left main and proximal circ very well to avoid any entrapment of the burr. Then we performed IVS, and so multiple fractures. We continued to modify the lesions. We use multiple non-compliant balloons at very high pressure, and then a 3.5 millimeter shockwave balloon delivered these shocks across the left main, proximal LAD, and circumflex. I was not happy of this IVUS, despite the fact we did use NC balloons and shockwave. You see at 4 or 5 o'clock, the ostium of the LAD with a wire in it, but the circumflex does have an almost 270 degree of arc of calcium with no fracture. So we used a 325 millimeter Wolverine cutting balloon at high pressure, 20 or 22 atmospheres, which is not recommended, but we were able to create some fractures now on the right picture. I was post at 12 o'clock and 10, you see 2 nice fractures. Then we proceeded with stenting of the mid-circ using a 275 and 20 times 20 millimeter synergy and the left main artery into circumflex using a 35 28 millimeter synergy. We post-dilated very aggressively using a 4.5 millimeter for POT in the left main. Then we tried to recross into the LAD. This wasn't easy despite the fact we performed multiple balloon dilatations across the ostium of the circumflex and distal left main. Finally, we used twin pass and block technique. We're able to cross into the LAD using field direct steer, then exchange the wire out for regular Sheehan. And again, further balloons and IVUS, showing multiple fractures using the tap technique, which I do not usually prefer, but I proceeded with it anyway and stented the left main using the LAD using a 3.5 16 millimeter synergy. We performed multiple simultaneous kissings at using 4.0 and 3.5 and POT using 4.5 millimeter. I always like to finish with simultaneous kissing, which can be debatable. Final angiography revealed great result with TIMI-3 flow in all the vessels without the loss of any side branch. Just for the sake of time, these are the guidelines. You know, I just don't understand the concept of when some people say there is PCI doesn't work, medical therapy is better, despite the fact patients are on maximum medical therapy, they continue to be symptomatic. Well, clearly for patients with left main disease or patients with a stable ischemic heart disease, they do deserve to have a discussion regarding revascularization. I understand that 3-vessel disease in some patients, most of the patients might do better and might be better candidates for CABG, but PCI does have a class 1 indication to improve symptoms and does, according to our guidelines, recommendation for revascularization to reduce cardiovascular events has class 2A indication. So I do not believe that it is proper anymore to keep telling patients that PCI doesn't work or PCI does not improve hard outcomes. In conclusion, medical therapy alone is not always the correct or proper approach. Patients must be informed about all the available options, and we hear the term too aggressive or overly aggressive, but we do not hear inappropriate conservative therapy. Thank you.
Thank you very much, Dr. Iyad. We're going to open the floor for discussion. Audience, if you have any question, and our dearest panelists, if you have any comment or any questions to the speaker.
One comment, I think, was echoed twice. I think it's very important. We need to be appropriately aggressive in terms of PCI, because after collagen ischemia, we've seen a shift, as Dr. Iyad said, towards too conservative approach. And that's hurting some patients. I think we need to always highlight which are the patients who will be harmed by conservative approach, because a lot of interventional cardiologists are kind of shying off from cathing people, intervening, because they say, oh, it doesn't make a difference. In certain subgroups, it makes a negative difference if you leave the patient on conservative therapy. Some patient needs to be addressed, and I think this has to be echoed over and over again in such conferences. You don't want to be overly aggressive, but you really want to be appropriately proactive. So I think that's my main point. My main comment to Dr. Hadi, I think we need to hopefully spread more data about heart failure registry, because this is very important for Jordan. And hopefully we have like one big symposium to discuss all the data soon, because this is very essential in terms of what we know or what we need to change in our practice. Thank you.
تفضل دكتور هادي.
Yes, thank you very much. Spreading it, of course, is going to spread. I mean, this is the first time I presented. So, so it's going to spread. We'll share it with everybody. I think the way I see it to be more organized, and that's the message I put in the last. The Jordan Cardiac Society, Dr. Yousef معنا, must create working groups for each of the interest groups which we have. And through this, we make conferences, we make meetings, we spread news, and we have plans for the future. This is, in my opinion, the only way to have everybody in the kingdom, cardiologists and whoever is interested in cardiology, to be involved. Thank you very much.
Yeah, can I? Yeah, thank you very much, Hadi. Very nice, comprehensive presentation. But I want to ask you about this data now which become available. And as you know, in many parts of this world, intervention has been applied. And it corrected all the number that you think it's good, including medication use, including test use, including outcome, even by finding national group and centers who take care of this complex issue. Thank you.
Thank you very much, my friend.
دكتور هادي قرب الميكروفون شوي دكتور هادي.
Last year, I proposed, and Iyad was amongst us too, that we must create a Jordan cardiovascular research group entity. People interested in research in this room, if they have an idea, where would they go? Tell me, where would they go? They have to find somebody interested in research, Hadi, Iyad. You know, this is not the way it works. I am looking for a local type for Jordan, for us all to work together. اللي بيحكيه الدكتور كتير مهم. In order to amalgamate all the data we have, in order to encourage the young to be part of this, we have to work together, yes. We must work together. It doesn't make sense إنه in the middle of the night واحد منا بصحى بقول أنا بدي أعمل research على شو بعرف no reflow. It doesn't work this way. We have to work together, get the ideas between us, so we get excellent data out of this. Thank you very much.
Thank you. تفضل دكتور.
Dr. Hadi, I have a question to Dr. Hadi because we were so optimistic with the result of the JOR-HF trial and three interesting results from this trial or registry that most of the patients are having mitral regurg, which is significant mitral regurg, more than 60% in heart failure. This is something which is alarming to us. The second thing is that most of the patients are under treated with prognostic agent. So the prognostic agent are underused in this locality, and I think the same thing which is applicable in Jordan to the area, Iraq, and so on. The other thing is that the same notes in the last year, I told you that more than 50% of them have a normal ECG, which is not so expected in this patient. Do you agree with me that we can progress and put a plan for the next or the future for the mitral repair, some health program to promote the medical optimization of the medical treatment, and why we are underestimating the heart failure treatment?
Thank you very much. I tend to agree with that. The mitral regurg patients that I showed, moderate was hardly 40% and severe was 12%. We all know that a lot of, when you look at the mitral clip data, a lot of people, as you mentioned, which is important, You enter them in the data, you put them on the maximum medical therapy needed, you put them on CRTD if they are actually candidates for it. And what happens? They end up not being even amantaclib patients anymore. Because if you use the guideline therapy, you will be surprised how many patients drop off the list actually of a transplant in Europe and America, just simply because those patients were pushed to the guideline therapy to the maximum dose tolerated. Yeah, I tend to agree with you. I do. Thank you very much.
Thank you very much.
Can I just have one small last question here? Hadi, everybody's really interested in your heart failure study here.
Oh, hi.
Yeah, I've just a small question, just for your insights, really, because we were all sat here very surprised by how low the utilization of guideline-directed therapies in Jordan. Just your insight as somebody who practices in the region, why do you think that is? Is there a specific reason that you looked at?
Thank you very much, Hani. Welcome to your hometown, anyways. When you look at the slides I put for the medications upon entry, actually you find that almost 50% of the patients were on RAS inhibition. So what's happening, what I'm saying is that the 4 pillars, when you put them together, okay, that's where it's underutilized. So you find more than almost 60% plus of the patients had 3 pillars, like the SGLT2 is not there, and so forth. And that's where we have to work on, encourage people to stick to the 4 pillars. Hani, what's happening is a lot of our colleagues shy off when they see the patient in front of them in the office with heart failure. What happens? Blood pressure is 113/74. So why not start the 4 pillars together? That's what happens. They say, the blood pressure is soft a little bit, I will give Entresto, then I will add beta, and so forth. It doesn't work that way. Okay. That's where the problem. Of course, cost with ARNI is an issue with the SGLT2, no question about it. And shying off little things like having a potassium of 5, then they stop. I would not give, etc. We can talk about that in details, Hani. Thank you.
So another question from the panel, please.
I have a comment for Dr. Mirvat. Thank you for a great talk. Something we didn't touch upon is the surgically ineligible patients and where those people stand in terms of having, the Impella or the ECMO or the ECPella now they're talking about. And, I think our use of these MCS is dismal here because of probably the financial issue. So if we're talking about 50% use in the West, I think we might be talking about less than 10%. So what do you do with these surgically ineligible patients, and how do you guys handle them where you are?
So surgically ineligible is part of the heart team discussion. So all these cases really should start with the heart team or the multidisciplinary team meeting. Not every case that's surgically inoperable requires mechanical support. And not every case that doesn't, require surgical input doesn't need support. So sometimes you have a patient who's high risk, but doesn't need to go to surgery, but you're going to do, for example, rotablator or what have you. These are patients that you may have poor reserve and you may want to use circulatory support in these patients. But just without rambling, going back to your point, all these cases where you're going to be considering high risk, you need a heart team meeting. And the surgeons are integral to the discussion. I would say cardiac anesthesia, heart failure experts are part of the discussion as well. And I think the heart team has grown and matured in the era of structural heart. But I think we have to remember that it started with the coronaries. And so this is a prime example that if you're going to do a high-risk PCI, make sure your surgeons are on board that this is not an eligible patient, or that PCI is at least equivalent, if not better, in this particular patient.
I guess I wanted to emphasize that you should use a planned MCS instead of prophylaxis because the difference in the mortality is huge.
Absolutely. So if you're going to consider support, then in my opinion, using it up front rather than waiting until a complication happens. And we've seen that from the evidence from the balloon pump all the way to Impella, that when it's on standby, yeah, we've all done that, we say standby, but actually the outcomes are worse. So it's either use it or don't, but if you're going to use it, then you may as well use it full-blown and get the support you need.
Any question for Dr.
Yes,
Mirvat?
sorry. Excuse me.
Yeah, thanks, Dr. Mirvat, for always elegant presentation. But this is my question, like I probably, when I did my cardiology at USC in 1996, intra-aortic balloon pump used to be, and then the idea of the physiology of myocardial dysfunction, whether stunned, hibernating, or like there is common sense where those mechanical support should work. So what do you think the problem is? Selection, timing, deciding what's the proper for that particular patient, or what it is? Thank you.
So very quickly, timing. I think when you already have heparin on board, you're halfway through the procedure, your patient is already crashing from no reflow. Yeah, the risk is much higher for you now to get large bore access and put in a mechanical support device. So timing is an issue. But really it is selection. And I know when I graduated, maybe 13, 14 years ago, my threshold to use support
You mean 6 years ago, Mirvat?
6 years ago, I'm still, yeah. So my threshold was very low to put support. With experience, you learn to select better. I don't need to subject 80-year-olds with peripheral vascular disease to mechanical support if they don't absolutely need it. And so you start to be a little more appropriate with your selection process. What we do is we look at EF, but not just an absolute number as an EF. You see, was this patient admitted with pulmonary edema? Is the EDP high? They don't do well irrespective of the EF. So even if the EF is 35, they may still do poorly compared to someone with an EF of 20. And then we look at the complexity of the anatomy, the syntax score, how much calcification, how much atherectomy am I going to need to do? Is this the last remaining vessels? Those are the ones that I fear. Last remaining vessels, high EDP pulmonary edema, honestly. And that's where my threshold is very low, or recent MI.
We have a question here, please.
Yes, thank you very much for this top-level, phenomenal presentation of my colleagues. So I want to ask some points for the first lecture presented very perfectly and very nicely by Dr. Mirvat. Before we are going to the insert, mechanical circulatory support, several questions should be answered. First of all, when and how? Secondly, is there any superiority of one device over the others? And thirdly, when to wean? As we know, there is some conflicting regarding the recommendation by the guideline, upgrading, upgrading by the American, downgrading by the European guideline. So when we are going to use, very simply and practically should be follow the PCI protected algorithm with a score more than or equal to 4, it's strongly recommended to insert mechanical circulatory support. 2 to 4 might be considered, below 2 there is no indication at all. Second question, which device is superior to others, whether Impella or intra-aortic balloon counterpulsation? As we know, the intra-aortic balloon counterpulsation significantly decreased the afterload, but got inefficient to augment the cardiac output. But it's a very extensively, very popular, great familiarities with intra-aortic balloon. Incomparable to the Impella. Impella augment the cardiac output very sufficiently with a strong hemodynamic support, even with a negative pulsatility. But the trial, if we are following the PROTECT 2 trial, that showed that there is no 30 days mortality difference among two groups, possibly the later outcome in favor of use of Impella. Thank you very much.
Very excellent summary, very excellent summary. Go ahead. Okay, go ahead.
Thank you very much. The other question about, or the comment to the Dr. Hadi. Dr. Hadi today. Sorry, Dr. Hadi, about the registration, very, very good registration, and it's very good job. But I have a question about the acute heart failure. You mentioned that there is the beta blocker is more taking in the acute heart failure, not in the chronic heart failure. I think it's beta blocker not given in the only when they stabilize of the patient of the acute heart failure. You mean that is outpatient, in the patient or outpatient? This is one. The other, the SGL2 and the ARNI must be given after stabilization of the acute heart failure, not given in the during of the statement of the acute heart failure, that's meaning pulmonary edema. The definition of the stabilization about the blood pressure and the given IV diuretic, you give these all RNA, SGL2, beta blocker during the admission of the acute heart failure or after discharge or pre-discharge. Thank you very much.
Thank you for the comment. Actually, the patients who were entered in the study, a good number of them were already on beta blockers. Now, for the acute decompensated heart failure, of course, what I put the slide, it was the pre-discharge maximization of medical therapy, added on type of new medications, maximizing therapy. I totally agree with you. We don't actually jump on the wagon and start giving patients while they are on maximum IV diuretics, sometimes inotropes with beta blockers, SGLT2. We wait until they stabilize and pre-discharge we give the medicine. So I agree with you.
Thank you.
Okay,
Thank
we
you.
have a question here. Last one.
Just, I have a comment for Dr. Mirvat. Thank you very much for your presentation. Dr. Mirvat, I think using mechanical support I think when I had the luxury to have the mechanical support available in the cath lab, I will use it more and more frequently. That will reduce mainly the stress of doctors who are the operator, hoping to get a better result for the next. But when we haven't the easy access for these devices, the indication will be very limited. This is my comment for you. Just to finish rapidly, for Dr. Hadi, if we are talking about the 4 pillars of heart failure therapy, we should take many things in consideration. 2 things are very important. The treatment and the dispersity of many generics we have. Second thing is the insurance. Before talking about treating patient without evident and a stable insurance system, we can't treat them very well. Thank you.
Thank you. With that, we're gonna come up to the conclusion of this excellent starting session. I would like to thank my colleague, the co-chairman and the panelist, and the speaker and the audience, and I hope you're going to enjoy your coffee now. Thank you very much.
يلا يعطيكم العافية. 30 minutes معكم قهوة وشاي وتفضلوا.